There's a lot of activity going on in the OCT world. You may have heard recently that Abbott has released the next generation of OCT called Ultron. We just did our first cases of it really about 15 or 20 minutes ago. And so more on this in the future about the next steps of OCT. But the good thing is, as Gary has probably described to you earlier, is the importance of developing an algorithm for intravascular imaging is really what gets the best outcomes. Okay, so the best way to handle this, I think, or to talk about MLD max in the context of a case. So this is a fairly typical case we'd see in the cath lab: moderate right coronary disease, complex bifurcation disease, and a proximal LAD lesion. As is typical in many centers, we calculate the Syntax score in patients with triple vessel disease. This patient has a Syntax score of 22, and the patient elected to undergo PCI, which really means we have to get cabbage-like results specifically on the LAD. So how do we make OCT easy, or in fact, how do we make intravascular imaging easy? We really need to focus on those areas that have evidence to suggest large relative risk reductions in PCI complications and improve PCI outcomes. So we know that in the pre-PCI, we need to understand the morphology, specifically.
Can you make it full screen, please? We are just press the button below. We are seeing half.
Oh, I'm sorry. I thought I was full screen. Well, how do you see it? Is it still small?
We still see slide view, Ziad.
Sorry about that. I'm actually on primary monitor.
Hit F5. Usually that works.
Yeah, I'm actually seeing, 1 second, guys, sorry. I'm actually seeing the, I'm going to do a new share here.
Probably you can stop share and do it again.
To jump ahead, in the pre-PCI, we know we need to look at the morphology, which is largely an assessment of calcification. We need to determine accurately the length to make sure that we cover the lesion and also that we land in the most normal segments distally and proximally. And obviously the diameter of the stent indicates how much lumen area we're going to get and is probably the most important predictor of long-term PCI outcomes. Post-PCI, we want to look for medial dissection, and because we know that the presence of an edge dissection, particularly at the distal reference, is an independent predictor of target vessel failure. We're looking for apposition largely to prevent us from getting into complications if we need to re-intervene. That's gross areas of apposition, and we know the clinical utility of expansion on PCI outcomes. And so we termed this MLD max because it's something that's really germane to interventional cardiologists. We all want to try to get the maximum MLD, and this is an easy way to remember the steps of an imaging-guided PCI and apply them into practice. So for OCT-guided PCI specifically, I do want to spend just a couple seconds on how we set things up. You connect the syringe and flush the catheter with whatever medium you're going to be flushing the artery with. So if you're doing a saline-guided OCT, this should be saline. If it's contrast, it should be contrast. You purge the catheter with that material, and that's simply you're following the steps here on the bottom right-hand corner of the screen. After that, you're going to go ahead and drape the dock. It's very important that you do not hold this black cable and hang the OCT. There's about $100,000 worth of fiber optics in there, and every time you bend this, you damage some of those fiber optics and your image will get worse. And then you simply connect the catheter, and then you follow the instructions on this. Requires automatic measurements. The OCT is able to detect all of these automatically if you get a good flush clearance. It provides you the L mode and the lumen profile, which is on the bottom. More on that in a moment. And there
can actually visualize the coronary artery directly, three-dimensional.
Zoom out feature, because in the past when we had the M6 signal attenuation, and to understand that, let's take this hypothetical situation where you algorithmic approach of looking in the rope and the adventitia and looking in the lumen or the wall and understanding high or low attenuation. We're very quickly able to determine what the lesion morphology is for all OCT cross-sections. Now, the most important one from a clinical standpoint is actually the low attenuation signal that you see in the wall, and that's in the lumen, in the wall, and that is calcium. So what you'll notice, if you know calcium is a crystal, so if you shine light through a crystal, the light will refract, and so you're able to see behind it. And the reason calcium is important is because it is the one parameter on morphology that is the most likely to get you into trouble. Because fibrotic and lipidic lesions yield after even direct stenting or compliant ballooning, and even if you end up a little bit relatively underexpanded, high pressure post-dilation can really rescue these areas. However, in the presence of moderate to severe calcification, that's completely different. And once the stent is placed, apart from maybe some preliminary data about IVL rescue, really you're in a difficult situation here. So when you see moderate to severe calcification, you need to think about advanced lesion preparation. We developed this calcium algorithm called the calcium imaging score, in which we created a simple strategy called the rule of fives, where if you have a vessel that's got calcium that's 0.5 millimeter thick, 5 millimeters long, and 50% or more of the vessel arc, you're more likely to be underexpanded, reminding you that advanced lesion preparation, whether it be NC or specialty balloon or atherectomy or IVL leading to calcium fracture, is critically important. And this is an example of calcium-dependent lesion preparation where the pre-PCI M for morphology is critically important. You see that there's dense calcification in the artery wall. We perform atherectomy to thin this calcium down. The calcium is fractured by an NC balloon, and then you can get excellent luminal gain. Now, when you do an OCT-guided morphology assessment, it really can be done very, very quickly, and all you're seeing is us scrolling through the artery here to look for segments of calcium that are more than 180 millimeters, more than 0.5 millimeter thick, and greater than 5 millimeters long. When we do the length portion, what we're really trying to do is manipulate the angiogram. So if you look at the OCT co-registration angiogram, what the OCT 3D luminogram or automated lumen profile is really a multiplanar reconstruction very similar to TAVR. You've essentially squashed all of the images and the three-dimensional nature of the artery into 2D, and that helps you to determine the optimal reference segments. So when we do that, what we're going to try to do is land our stent into the most normal segment distally, and we want to examine the cross-section and say, yes, this is a nice place for us to land. We want to do the same thing proximally. And when we do this proximally, we notice that there's a segment of disease here. However, this may be the most normal segment of this artery. Now, we don't have a 35.2 millimeter length, and to fit into the concept of precision PCI, we should manipulate the more normal of these two segments, and in this case, that's the distal, by basically pulling it in 2.2 millimeters, and now we end up with a commercially available drug-eluting stent. The external elastic lamina and measure it quickly. We round down to the closest device that penetrates into the media, particularly at the distal edge. There is a risk of progressing into an intramural hematoma, and we strongly suggest stenting these when they're greater than 1 quadrant in arc from the center of the vessel and they penetrate the media. You can see that it's very easy and quick. Luminal wire. Yeah, very quickly. This procedure was 25 minutes beginning to end with cabbage-like results, 100% expansion, absence of malapposition, and absence of an edge dissection. So thanks for listening to my talk on MLD Max, and I invite you all to join us for our OPCI Live, which is an ongoing program for.
We had some impression about how the OCT is done. Actually, OCT is a very important technique, and we have been using quite a lot, not in Apollo as of now, unfortunately, or whatever, because it is actually for the complex PCIs, not a routine procedure. It gives an idea about the plaque, it gives idea where the stent has to be placed, and it actually stent optimization so that we don't have stent thrombosis. To give you another insight, because cardiology has been evolving branch, when we had a stent technique coming up, there was a good number of patients of stent thrombosis, because finally the stent actually is a foreign material. So all these studies, all these new technology is to reduce or almost nullify the possibility of stent getting thrombosed. You see, you have a patient where you put a stent and a patient get thrombosis inside the stent. It's like an acute MI, it's a very emergent situation. Although the rates are quite low, now earlier when the stent came up in 1987, it was about 0.5 to 2%, which is quite high, I would say. Now it has gone down to 0.2% or 0.05%. Fortunately, it has never happened in my case personally. But of course, these technologies are important for that. Coming back to the implanter device, this is a video which we have done in Apollo Hospital.
13 मई 2023 एक पेशेंट हैं जिनको हार्ट में अलग अलग तरह की बीमारियां होती हैं। सबसे कॉमन तो हार्ट अटैक है जिसमें नसों ब्लॉक होती हैं, और दूसरा कॉमन बीमारी है रूमेटिक हार्ट डिजीज जिसमें वाल्व सिकुड़ जाते हैं। तीसरी है एओर्टिक वाल्व स्टेनोसिस, और एक और बीमारी है जो बचपन से होती है।
This is actually in Hindi for the public purpose.
हार्ट के अंदर छेद होते हैं।
It's better to speak sometimes your own language.
तो होल इन द हार्ट कैन बी इन द अपर पार्ट ऑफ द हार्ट और लोअर पार्ट ऑफ द हार्ट। अपर पार्ट होता है एट्रियल सेप्टल डिफेक्ट। इस वन ऑफ द कॉमन एबनॉर्मेलिटी जो कि सिंस बर्थ होती है, लेकिन पेशेंट को पता ही नहीं लगता। बर्थ से होती है लेकिन पता इसलिए नहीं लगता है क्योंकि ये इसमें लेफ्ट टू राइट स्टंट चलता रहता है, और कई बार मिस हो जाता है। 40-50 साल पता लगता है, तब तक लेट हो चुका होता है, तो हार्ट की लाइफ कम हो जाती है। ये हमारे ऐसे पेशेंट हैं जिनको 36 साल की उम्र पे चांस डिटेक्शन हुआ, जिन्होंने होल बॉडी चेकअप कराया था आपने, तो होल बॉडी चेकअप पता लगा कि हार्ट के अंदर एक छेद है जो कि जन्मजात है। तो किसी को पता लग जाएगा, एकदम बिल्कुल नॉर्मल आदमी है, बिजनेसमैन है, कि हार्ट में छेद है, तो घबरा के उसको दो रात तो नींद नहीं आएगी। फिर डॉक्टर समझाएगा कि नहीं, ये बीमारी ज़्यादा खराब नहीं है। तो जो छेद होते हैं हार्ट के, वो कई तरह के होते हैं। कुछ ऐसे होते हैं बच्चे जो पैदा होते हैं ब्लू बेबी, वो ब्लू बेबी वाले जो होते हैं उसमें छेद के अलावा कई जगह और खराबियाँ भी होती हैं। वो सिंपल छेद होते हैं, जैसे कि इनका है एट्रियल सेप्टल डिफेक्ट, वो हमने पकड़ा, उसमें इको किया। इको हमने फिर इनको यहाँ बुलाया, ही लिव्स इन गोवा, और गोवा में रहते हैं, तो इनका ट्रांसइसोफेजियल इको करके हमने आज बंद कर दिया उस छेद को। कैसे किया हम बताएंगे आपको, लेकिन पहले हम इनकी एको की रिपोर्ट हम दिखा रहे हैं ये कि एको में क्या क्या है। तो एको देखिए, इट हैज़ लार्ज ऑस्टियम सेकेंडम, ASD मतलब एट्रियल सेप्टल डिफेक्ट, एंड शंट 2:1। एओर्टिक रिम आर डिफिशिएंट बट अदर रिम्स आर एडिक्वेट। सबसे इंपॉर्टेंट बात है, डिवाइस अपीयर्स टू बी डिफेक्ट अपीयर्स टू बी डिवाइसेबल। तो जो ये जो छेद होते हैं, इसको बाईपास ओपन हार्ट सर्जरी से भी बंद कर सकते। छाती बिना खोले जैसे एंजियोग्राफी की जाती है और जैसे एंजियोप्लास्टी करी जाती है, वैसे ही एक स्पेशल तरीके का छाता होता है। अभी हम दिखाएंगे, देखिए लगा हुआ है ये, इसमें जो लगाया है कैसे दिखाया बताएंगे। जो ये छाता है इधर की तरफ और इधर कर, ये बटन है, और जो छेद था छेद के अक्रॉस लगा दिया, तो उसको हमने डिवाइस से बंद किया। तरीका वही होता है। सिस्टर देखिए यहाँ पे प्रेस कर रही हैं, हमने उसको ट्यूब निकाल दिया। कहाँ से किया था, जांघ की नस से एक ट्यूब डाल के, और ट्यूब जो दिखाते हैं वो ट्यूब डालते, ट्यूब के थ्रू एक छाता, अम्ब्रेला, कुछ भी कहिए उसको, कहते हैं एम्बलास्टर डिवाइस है। ये बड़ी वाली ट्यूब है जाती है, जो ये ट्यूब जाता है हार्ट के अंदर छेद के अक्रॉस, और उसके बाद हम उसको छाते को रिलीज़ कर देते हैं। ये सिस्टम है जो देख रहे हैं, ये रिलीजिंग सिस्टम है, और इसमें एक डिवाइस जो कि छाता जिसे बताया आपको दिखा लग चुका है, उससे बंद कर दिया। इसको कहते हैं डिवाइस क्लोजर ऑफ एट्रियल सेप्टल डिफेक्ट। इट इज़ ए नॉन सर्जिकल टेक्निक, कोई ऑपरेशन नहीं, कोई बेहोशी नहीं, केवल जांघ की नस में एक लोकल एनेस्थीसिया देके 25-30 मिनट में होता है। एक्सपर्ट टेक्निक है, इसमें काफ़ी स्किल की ज़रूरत होती है, क्योंकि किस जगह छाता रिलीज़ करें, कहाँ पहुँचाएँ, क्यों ट्यूब डालें, मल्टीपल थिंग्स आर देयर। फाइनली यू आर प्लेइंग विद द हार्ट, हार्ट के अंदर सब कुछ हो रहा है, तो नो चांसेस। एंड जैसे हमने एक एक करके व्यू दिखाता हूँ। इनके पहले एंजियोग्राफी की जांच भी करी हमने। 37 साल की उम्र है, आजकल सिगरेट स्मोकर हैं ये, तो ऐसे पेशेंट में हमेशा एंजियोग्राफी की जांच करके चेक करते हैं। एंजियोग्राफी की नस सारी नॉर्मल है, विदाउट डिस्पाइट हैविंग ए स्मोकर ही हैज़ गॉट नो ब्लॉकेजेस। इट्स ए गुड न्यूज़ फॉर हिम। एंड तो कोई ब्लॉक नहीं है, कोई स्टेंट की ज़रूरत नहीं है, किडनी की नस भी ठीक है। इसके बाद हमने एक ट्यूब डाला जो कि यहाँ पे राइट एट्रियम से लेफ्ट एट्रियम में पहुँच गया छेद के थ्रू। ये देखिए, ये छेद के थ्रू नॉर्मली यहाँ तक नहीं पहुँचता, यहाँ पे सेप्टम होता है, तो वहाँ पहुँच गया। उसके बाद हमने चेक किया, फिर बड़ा ट्यूब डाला, और बड़ा ट्यूब हमने ये डाला। देखिए यहाँ पे ये लेफ्ट पल्मोनरी वेन है, लेफ्ट पल्मोनरी वेन के अंदर रख के एंड देन इसको डिवाइस को अंदर लेगा, ये छाता है, ये ट्यूब के थ्रू चला गया और अभी रिलीज नहीं किया है, पीछे खींचा, रिलीज पूरा नहीं हुआ, इसको रिलीज हो गया है लेकिन यहाँ से डिस्कनेक्ट नहीं किया है। और उसके बाद हम नेक्स्ट व्यू में चेक किया हमने फिर से कि यहाँ बिल्कुल यहाँ पे नॉर्मली जैसे ही मैं डाई डाली ना, ये डाई इधर चली जाती है, इधर भी जाती है, तो वो नहीं गई, इसका मतलब ये बंद है। इको से हमने चेक किया फाइनल, इसको इको भी करा हमने साथ साथ, और उसके बाद इस डिवाइस को हमने रिलीज कर दिया। ये देखिए अलग हो गया और हमने इसको ट्यूब जिसके थ्रू गया था वो निकाल लिया। तो ये देखिए ये यहाँ पे है, अब फिर चेक किया, उसके बाद हमने सब कुछ निकाल के अब ये केवल डिवाइस अंदर रह गई है। तो दिस इज़ अ फैंटास्टिक टेक्निक एंड इट हेल्प्स इन अवॉइडिंग सर्जरी and with a good result. Dr. Vigupta from Apollo Hospital, New Delhi on 13th of May, talking about the ASD closure with the Amplatzer device, which is the device for this. So हमारे ये दोस्त हैं जो गोवा से आए हैं, इनकी शक्ल दिखाए बिना एक गाना सुनेंगे। ये गाने के शौकीन हैं, गोवा में तो लोग बीच पे गाना गाते हैं, कोई भी गाना गुनगुना दीजिए, शक्ल मेरी दिखाई दे रही, गाइए।
I ask patient to sing a song just after the
भावना
procedure.
बताइए,
Sometimes they agree, sometimes they don't.
बहुत अच्छा एक्सपीरियंस था। अच्छा
यू आर
एक्सपीरियंस।
हैप्पी ना? ये दुबई जा रहे थे, पहले सोचा था कि दुबई पहले होके आ जाए, मैंने कहा ठीक है होके आ जाइए, लेकिन दिमाग में टेंशन। Dr. Vigupta from Apollo talking about the Amplatzer ASD closure, device closure, non-surgical technique, talking about this and
About this technique, and Dr. Kapoor comment, because he has been doing a lot of echoes, and just one quick comment about rims. How do you diagnose the rims are adequate? Because the most important limitation of doing a non-surgical device closure is the non-adequacy of the rims around. So can you just elaborate about with the interest of the audience?
Yeah. So we have a number of rims which are there around the ASD, and they should be adequate, which means that how much they will be, that they should be at least 4 millimeters or so, at least that much rims should be there. And there are various types of these rims have been defined. So whether they are present in the aortic area. Now the aortic rim, even if it is deficient, you can still do the device closure. But the other rims that are there, if those rims are very important. So if they are less than 4 millimeters or so, then it will be very difficult to do a device closure on those rims. So those rims that are there, they are diagnosed on echocardiography. We look at the apical four-chamber view especially, and we look at the subcostal views, and we also look at the short axis views. So in these views, we can make out that what rims are there. Now you diagnose them as AV canal rims if they are close to the AV valves. They're close to the mitral and tricuspid valve. That part of the atrial septum, we call that area as AV rim. Then we got SVC rim, where the SVC is entering. That rim is also important. So we use that practically in the apical five-chamber view. We look at the SVC and we look at the SVC rim. Then we got IVC rim, which we look at in the subcostal view. So that part of the atrial septum, which is formed by the IVC, that area, if it is deficient, then again the device closure cannot be done. Then we have got, of course, these anterior rims, the lateral rim, but all these rims that are there, only the aortic rim, if it is deficient and rest of the rims are more than 4 millimeters, we can close that by device closure. But if any of the other rims are involved, then the device closure cannot be done.
Kapoor for elaboration. I think everybody is clear that ASD is a common disease, normally missed out. Just to summarize, it does not cause major symptoms unless the patient becomes 30-year-old or 45-year-old. It is actually silent hole inside the heart. It can cause major implication if missed out, especially it causes pulmonary hypertension and then lead to left. Initially it is left to right shunt, and then it becomes right to left shunt. And when it is right to left shunt, it is inoperable. You can't do anything. This is known as Eisenmenger. And here we have to, the patient mostly have a chance detection on echocardiography. Sometimes they have symptoms of mild dyspnea, breathlessness, and that can pick up. And unless you do echo, you are not aware. But of course, a good clinician can sometime pick up with a stethoscope. But normally, with the less and less usage of a stethoscope in today's technology, most of the people are missing out this thing because you can have a small ejection systolic murmur. So I'm going to talk now. We move on to the next session. I would request Dr. Kapoor to stay back and Dr. Kundu because the next session will have a talk by myself, and then Dr. Mukesh Goyal will talk about heart transplantation, and Dr. K.K. Pandey, and then we will have session on artificial intelligence, a talk, very important talk which you should listen. So I think without wasting time, we are already late by half an hour. I will start my talk, which is a very important topic because there are a lot of clinicians and angioplasty here, and please connect to this. The management of, you can see the topic, I think everybody has scientific program, angioplasty versus medical treatment in chronic stable angina. So okay, now we have it. So this is very important because there have been some studies which have shown that in chronic stable angina, we do not require angioplasty. And as an angioplaster, myself as a interventionist, I do not completely agree, but the trials had shown something like that, so we have to discuss about these things. Chronic stable angina means the patient has a chest pain on walking, the patient will have no chest pain on the rest, and the chest pain will be on walking only, and it is quite stable. 30 minute he walks and then he has pain, and you do angiography and you find blockages. Whether we should do angioplasty